Hi there, class. My name is Kathleen Alejandro. I am a master's graduate student with Liberty University, and this is my final assignment presentation on Blood Products 101. So, welcome. Our learning outcomes we'll talk about real quick. Just want you guys to understand the different types of blood products, their indications for use. And of course, we're going by the National Practice Guidelines. Demonstrating proper preparation of blood products is very important as a nurse. That's a skill that you'll use very frequently in understanding the basic steps to blood product administration, whether it's routine, emergent, massive transfusions in a trauma room, understanding the differences and kind of the principles of care and monitoring of your patient. We'll kind of go through some case scenarios, have a few knowledge check questions, and hopefully you learn something out of this class. So in here you have some indications for use. The content will cover some indications for use, the types of blood products we'll be using, blood products and why we use each of those blood products. And of course, compatibility and testing is super important, but what do we do when we don't have the time to do that? And so we'll go over that as well. Administration of blood products and some basic principles, kind of two-part slide there, and then adverse effects, what to be on the lookout for and how to act immediately and appropriately for your patient. And then we'll go over some special considerations and special populations and things to keep in mind. Just a quick video I'd like to play here. I'm hoping this plays on its own. Maybe not. I will link it into this video so you're able to watch it on your own if you'd like. But it's just a video about how transforming the trauma care and how important blood products are. But just in your own thoughts, you can think about some patients that you think would require blood products. And maybe you've had experienced this in your own nursing career, your clinical time, if you're in an undergraduate program. Just some food for thought. Kind of think about what kind of patients would really use blood. How does the nurse play a role in the blood transfusion and caring for a critical patient? So this is kind of just a thought-provoking video, and I'll link it here for you if it's something you'd like to watch. Oh, there it goes.
Simple one. Saving more lives. That's what a new initiative called Brothers in Arms is aiming to do, and the initiative is helping transform trauma care right here in San Antonio. A disaster can strike at any time, but a program through the South Texas Blood and Tissue Center equips air medical crews with blood for patients who need transfusions.
We supply it to 18 different helicopter sites. A lot of places are doing it only at one helicopter. We're doing it in a much larger area.
Traditionally, patients would receive red blood cells, plasma, or platelets. But through the Brothers in Arms program, patients receive whole blood, which involves all components.
These people, when they're out at a car accident or they have an event where they need lots of blood, they're bleeding out whole blood. They're not just bleeding out red cells or just platelets.
Research shows that whole blood transfusions can give people a better chance of surviving traumatic incidents.
It's just needle stick and blood flows out. And like I said, you're done 20, 15 minutes tops.
To qualify, whole blood donors must be men with O-positive blood. Jerry Sandoval, a perfect fit for the program.
You never know who's going to need blood. It could be a family member, a friend. It's kind of like insurance. It's better to have it and not need it than need it and not have it.
And Brothers in Arms hopes that more men get screened for the program. If you're accepted, you'll be asked to donate every 8 weeks for a year. For more on the program, just head to...
So just some food for thought. We're going to talk a little bit about whole blood and kind of the new research that shows that it really supports trauma care, trauma principles of care. So these are just some examples of patients that could require blood transfusions. Your acute traumatic patient, of course, your GI bleeds could use a lot of blood. They could lose a lot of blood in their GI system. Vaginal bleedings, especially in pregnancy or post-pregnant, can have lots of complications with bleeding, requiring blood transfusions as well. Your sickle cell patients, we have an understanding of why that is, right? Anemia could be a reason somebody needs a blood transfusion. And of course, anytime there's a hemoglobin less than 7, I'm sorry, my face cuts it off there, but hemoglobin's less than 7 is definitely an indication for a blood transfusion. Now, what are some types of products? We'll kind of discuss this a little bit more in depth in the next slide. But you have packed red blood cells. They're the most common type of blood. Some platelets. Albumin I've kind of thrown in there because you'll see this as well. You have whole blood, which we discussed, and then you have plasma. So what would each of these products be used for? Like what kind of patients? I want you to start thinking about what kind of patients that we would use these kinds of blood products for. It's important that you understand the difference and know why you're giving each one if it's ordered for your patient. So here we go. So starting with our packed red blood cells, it's the most commonly transfused. It increases the patient's hemoglobin, their iron levels, and of course their oxygen carrying capacity in their blood. Typically given for acute blood loss, your GI bleeds, your vaginal bleeders, anemia, and of course surgery-related complication for blood loss. Red blood cells kind of has most of the components that we need to replace when there is blood loss as well. And then with platelets, it's typically given for patients, of course, with low platelets. But what do we call that? That's your thrombocytopenic patients with typically white blood cell count less than 20,000. You also are giving this because the patient might be immunocompromised, like your cancer patients. The chemotherapy will literally deplete them of their platelets. They will be intentionally thrombocytopenic, but that doesn't mean they have to stay there. You may require to give them platelets to give them a little bit of a immune booster. You also have high bleeding risk if you maintain low platelets, as we understand that does improve their clotting. And then you have targeted replacement. So you're only giving platelets. You're not also giving red blood cells with this. It's a targeted replacement of blood products, platelets specifically in this case. You have albumin. Albumin is considered a volume expander. So the time you'll see this being used is mostly for your burn patients where you're giving them massive fluids to keep up their blood pressures, to replace their loss. You don't want them third spacing, so albumin can kind of help expand the intravascular space to keep that patient from having that massive shift of fluid into the third space. Liver disease and liver failure patients can also be given albumin too to help them along. And then we talked a little bit about it already, but whole blood, it's really come a long way. It's the most complete blood product. It's called whole blood for a reason. It packs everything that our blood needs. If a traumatic patient specifically is just losing massive amounts of blood, this really, really helps them instead of us as a trauma team having to replace each component of the blood. This packs that punch. But as you saw in the first video, it's a very small population that can donate it, so it's still not as globally utilized. It's still a new initiative that they're exploring and researching quite heavily now. And then you have your fresh frozen plasma. What do we use that for? It's packed with proteins and vitamins that support your health. So patients that really don't have that available to them, that's like your cancer patients, any severe bleeding where it's depleted all of their proteins, plasma can really help sustain their clotting factors. You can optimally transfuse patients with not only liver problems, but severe infections, burns, your disseminated intravascular coagulation, your DIC patients that are really at risk for losing their life. Fresh frozen plasma can be administered alongside your red blood cells, or really any of these components to help these patients along. Here's the time for a quick knowledge check. Here we go. So which of these patients' populations would require an albumin transfusion after the slide we just reviewed? We have a 55-year-old trauma patient, status post motor vehicle crash with open femur fracture. You have your 32-year-old female with ongoing leukemia presenting to the emergency department with fevers of 101.3, that's Fahrenheit, and weakness. Your 21-year-old male with an open tibial fracture after skateboarding accident. Or a 61-year-old with burns estimating 49% burn surface area of third degree that has received 4 liters of LR boluses with urine output of 10 milliliters per hour. So really it's D is the correct answer, because our burn patients are at the most high risk for not only renal injury, but that third spacing we talked about from a massive fluid shift that happens, and that's to accommodate that systematic response to the severe burn. That inflammation that happens with the severe burn as well as a major concern. So these patients require massive fluid replacement to maintain that urine output. Your goal is above 30 mLs per hour, and that can be really difficult to achieve in the extendedly burned patient. Your fluid replacement is calculated using the Parkland formula. If you haven't heard of that, I do highly recommend you research that. But it's the TBSA percentage times the patient's weight in kilograms times 4 mLs per hour. Now, research is changing on this, so just make sure you're looking at the latest Parkland formula recommendations. But what you do is you calculate that, and then you half that total amount, and the first half should be given within the first 8 hours of the burn accident, followed by the second half administered over the last 16 hours. And so you have that targeted amount that you're administering to this patient, but also you keep in mind that we are no longer bolusing this patient to make up for the lost time should they have arrived 3 hours into the burn. So lots and lots and more I could teach on this, but that's a whole separate topic in and of itself. Just remember, albumin could be a really key use in the burn patient to expand their intravascular volume. Compatibility. This is probably one of the most important slides in this presentation. Just looking at this chart alone can really tell you a lot. Just looking at it right now, what's the universal blood donor? You can see it in the chart right in the orange there. Type O negative is your universal donor versus your universal receiver. Why are they different, right? And so this chart kind of gives you that explanation. Our blood, whether you're negative or positive type, tells you that's called your Rh factor, and that will tell you if you have the antibodies against a certain different kind of blood. And so you can follow on the chart and just look up at the top. If you are on the left-hand side column there, if you are a O positive blood type, which kinds of blood can you receive? You can receive O positive and O negative. Because with the positive Rh type, you have the antibodies for negative and for positive. So you can actually have both negative and positive blood types. Now, looking at your patient that is AB positive blood type, like me, you are a universal recipient because you have all of the, you have no antibodies, which means you can receive all kinds of blood and you won't react to them. However, to donate, if you flip the script, if you're going to donate your AB positive blood type, you can only donate to your own kind. So all of this is really beneficial for you to understand and really learn compatibility with blood type. But know that, of course, the laboratory you're working in is going to do the cross-matching and the antibody screening and the Rh blood typing before you receive a unit, unless it is an emergency release or a massive blood transfusion. And we'll talk about that here in a second. So administration of blood products, some basic principles. Of course, you need to consent the patient. Depending on the state you're in, nurses are allowed to consent in some states, but just know your facility protocol. Majority of locations require a provider to consent the patient. You are allowed to be the witness in that circumstance. Please make sure you're in the room when the patient signs that consent form. Educating the patient about the transfusion reactions, what to expect, what to report is extremely important. Of course, getting the blood work before the blood transfusion, that's that ABO-RH testing and the cross match. Using the IV pump every single time. Blood is never free hung unless it's a massive transfusion, in which point you'll use a rapid transfuser, which is essentially a pump in and of itself. And then, of course, the blood tubing with the filter is very important as well. That filter will remove any clots or any sediments that's left over in that blood. And we're always only hanging it with 1 liter of normal saline. Just be mindful of that. Part 2 of this is there's always a 2-nurse verification. Some facilities will recognize the EHR, the electronic health record, as that secondary nurse check. So you may not necessarily require a second nurse in person if your facility does acknowledge the computer system as that secondary check. Immediate set of vital signs right before you start the transfusion is very important. And then starting your blood within 30 minutes of pickup, that is critical. You should not start any blood transfusions after 30-minute window. That is a standard across the board. Bedside monitoring for the first 15 minutes is very essential. The nurse must remain with the patient that entire time. I like to check every 5 minutes. That is not a national standard. You do have to check at least at the 15-minute mark. But you're in with your patient for the first 15 minutes. Why not just keep checking and keep reevaluating and keep reassessing your patient? Blood must finish transfusing within 4 hours. So just making sure that the rate you choose to transfuse your unit is appropriate to finish that unit completely within the 4-hour window. And then no meds are to be given in the IV site while the blood transfusion is ongoing. Just keep it completely separate, because should the patient have a reaction, you will not know if it's from the medication versus the blood, nor do you know if the blood is compatible with that medication. So keeping those very separate, if that means starting a new line, if the patient absolutely must have something, then sure, then you can do that. Knowledge check. The provider orders 1 unit packed red blood cells for a patient with a blood type of O positive. The nurse knows the patient can have which type of donor unit. We know that O is the only type that can receive from other O donors. So they are kind of in a very lonely boat where they can be a universal donor, they may not be a universal receiver. So O negative is the only one compatible for this patient. Because if a patient is of a positive blood type, they can receive O positive or O negative. But in the options here, you only have O negative, so just be mindful of that. Adverse effects. Being on the lookout for this is extremely important. You have immunologic reactions to be on the lookout for, infectious reactions, inefficiency, I can't say this word. The blood product might not help at all, is what that means. And then you have other reactions. So what does that look like? That could be fevers, that could be chills, that could be urticaria, that's the itching, respiratory distress, hypotension, dyspnea, flank pain, hemoglobinuria, okay? So being on the lookout and asking your patient if they're having any of these symptoms is super important. Letting them know and educating them about these symptoms so that they can tell you, okay? Continuously reassess that patient, especially if this is the first unit they've ever received. What do you do? What do you do if this starts to happen? The very first step, and it will always be the first step, is stopping that infusion where it's at. That's what is likely causing this reaction. That is what we want to stop from further insult. So that normal saline that you hung, you'll bolus them right away to get kind of that system flushed as much as possible of that blood that could be causing this reaction. Continuous vital signs, of course, notifying your provider, sending the blood products and the tubing back to lab for further testing is very important because they're going to try to identify what could have caused this. And then there's usually some paperwork that goes alongside that, okay? Some special considerations, some special populations that we have to think about. You have your neonate, your massive transfusions, your emergency release, if you don't know a patient's blood type, and some religious considerations too. So with a neonate, what changes for this population? Really all it is the volume. You're not going to receive anything less than a whole unit of blood to administer. So knowing what is ordered and the amount ordered is very important so that you put it into your IV pump appropriately, especially in your babies. Massive transfusions, each facility has their own protocol, but typically between 4 to 6 units are given, and that's of universal blood type O negative. That's given, I apologize, of O negative red blood cells are given to for massive transfusion patients. Then you have to be mindful that in a massive transfusion, when you're giving over 3 units, these blood products are preserved. And this preservative that they put in the blood will actually deplete a patient's calcium level. So when you're about to give your 3rd unit, be mindful that this patient is going to be needing at least 1 gram of calcium between every 3rd unit they receive to replace their calcium, which has a lot to do with preserving their clotting factors too. It's a whole nother lecture I could do, but that is something to keep in the back of your mind. Over 3 units of packed red blood cells, just be mindful that they need to have calcium replaced, okay? Emergency release. How many units do you get with an emergency release? That's typically between 2 to 3 units of also universal blood type, unless this patient's been admitted, we already know their blood type, it's already been sent to the lab, it's already been resulted, then the lab may or may not give you universal blood type or something that they know is compatible with the patient. Unknown blood type, we talked about, they're going to get a universal donor. That's it. That's the safest option when you just don't know and you don't have time to know. They get a universal type. And then your religious objection. We learn about this in school. The Jehovah's Witness have a religious objection to blood products. But just because their religious beliefs happen to be Jehovah's Witness, that doesn't mean that all Jehovah's Witness are going to say no to blood transfusions. So keeping in mind to have that conversation with the patient, with the family, explaining the risks and the benefits to the blood transfusion is extremely important. And in summary here, let's do one more knowledge check. Your patient is receiving the first transfusion of platelets. They develop a sudden onset of shortness of breath and begin to sweat profusely. The nurse's priority intervention includes which action? Check the vital signs, including the temperature, notifying the provider's stat, immediately stopping the transfusion, or assessing the patient's airway for compromise and apply supplemental oxygen. Remember that the first and most important action will always be stopping the transfusion. Always make that the first step. It doesn't matter how bad you want to intervene in another way. The patient's only going to get worse if we don't remove the insulting problem, that be the blood. So stopping the transfusion will always be the first step. In summary, we kind of discussed the indications for use of blood products, the types of blood products that could be used, the indications for use of each blood product, compatibility and testing of blood before transfusing your patient, administration of blood products, some basic principles, and immediate actions to take if you do see an adverse reaction on your patient, and then some special considerations and special populations. I hope you learned something out of this video. I will be posting another video just showing how the setup looks, so stand by for that. Thanks for joining, guys. How to hang blood transfusion tubing, the proper way, how to do your proper verification. This is just a visual aid, a chance for you guys to get hands-on learning with the blood tubing, and kind of just the principles of care. Now, what I'm going to show you today is only applicable specifically with the Alaris pump models. Every hospital has their own kind of IV pumps. Here we use the Alaris pump, so that's what's going to be most applicable to your learning. Now, the most important thing, as mentioned previously in the lecture, is the blood will always and only be hung with normal saline. Preferably a liter in case your patient has a transfusion reaction. You can very quickly give them a bolus as appropriate. And so you always want to make sure you have the appropriate tubing. Blood tubing that's compatible with the Alaris pump, you'll see has this little blue, bouncy, stretchy side there that's going to connect to your Alaris pump, and I'll show you that shortly. I like to always recommend having your blood tubing prepared and ready to go before you even go pick up the blood at the blood bank. So of course, I have my patient. I'm going to verify that they're not febrile, that they have consented the patient. I have seen the witness to the consent, whether that's me or a third party, and also making sure that the patient understands what we're about to do. Now I'm going to prepare my normal saline bag as you see here. My blood tubing has already been spiked, and I've already ran it all the way through, primed my line, ready to go. Now just imagine I don't have the blood here. This is just my simulation blood that I have. But before I do spike the bag, I just came from the blood bank with my blood, and I'm going to find a secondary RN to verify this blood with me. Now on the blood there always has that reaction tag and that downtime charting tag. Most hospitals have this protocol where you can chart on here your vital signs, your transfusion reactions, should the patient have one. You'll have all these labels and tags that if you have the electronic health record, you will scan and verify. But with a second RN, you want to definitely make sure that you have the right patient, you have the right blood type, the compatibility that we talked about. All of those principles are going to be verified with the second RN. Now you're going to look at, with the second RN, they're going to read you the donor number, the unit number, the blood type, and the expiration date. And that second RN is going to verify that that's the product that you have on hand. And then you're going to swap roles, and you're going to repeat that. So now the opposite RN is going to read you the unit number, the expiration date, the donor number, and the unit type. And that way you have double checked to make sure that it's the appropriate type of blood to the appropriate patient, that is not expired. Of course, visualizing the bag for any visible clots or any tears or anything that just looks abnormal is also important. Now, as long as it's been within 30 minutes, you're going to hang your blood, you're going to spike your bag, and you're going to prime the line. You have 2 clamps on your line here. Your saline one should be the only one unclamped until you spike your blood bag. That's when you're going to swap off and you're going to clamp your saline side and you're going to unclamp your blood side. Okay, I like to only unclamp my blood side when I'm ready to administer the blood to the patient. Now we're going to go ahead and hook it up to our IV pump. And I like to do this before I turn it on. It minimizes the number of alarms that you will receive. Always clamping off your line before you unlock it. Now these come unlocked. This is just a simulation. Just pressing that right there. And now we're going to open our door to our Alaris pump, and you're going to insert the lock into the blue to blue, till you hear a clicking sound. And now you're going to close your door, close the lever, that locks in place. Now we're going to turn on our pump. Press and hold the on button. Let the system turn on. You've already have both spiked. They hang at the same level because you have your saline locked off. You've already primed your line so there's not going to be air in the line. And you've already spiked your blood. You just have it locked off, ready to go when the patient is ready. And when you're ready. Is this a new patient? You're going to say yes. Is this a critical care environment? Depends on the environment you're working on. For me in the emergency department is always a yes. And some institutions require you to put a patient ID information in your pump, so we're going to skip that portion for now. So we're just going to click confirm. And it's going to bring you to your channel settings. Let's pick our channel setting. We're going to go to IV fluids. You can pick blood right here, red blood cells. Is this the correct medication? Yes. And then you're going to pick your infusion rate. Everybody has their own preference on where to start. My practice, I like to start low and slow. Once we pass that 15-minute threshold of a transfusion reaction, then I like to speed it up to get it in within an hour or 2. Remember, you have a max time of 4 hours for this entire unit to be infused. So I like to start my patient off low and slow. Let's start him off at 65 mLs per hour. And then, of course, a unit is about 350 mLs. You can put that in there. Some people like to put a little bit less so you don't go dry, but the idea is that they get the entire unit. And then we would click start once this patient is connected and hooked up. Now remember that our transfusion time does not begin until the blood has traveled all the way in through the tubing and it touches the patient's IV. That's the start of your transfusion time. So if I keep this at 65 mLs per hour, and I'm going to sit here and wait until this goes all the way through my tubing, it might take quite some time. So one of my tricks is I like to speed up this rate, and I like to speed it up, let's say to 250, just until it reaches the tip of this IV. I'll start this off once it reaches the tip of my patient. I'm going to pause this and slow it back down to my starting rate of 65. Now, to each their own with their practice on that, just making sure you're not pushing a lot of blood very fast on a patient watching for those transfusion reactions. Now, that's just for demonstration purposes. I'm not actually going to run this. Any questions, please feel free to message me. I'm always available via email, or you can post a comment below. Here are my references.